there is not going to be time for me to tell you about our story and to have question time before that. So I would propose, apologize to those who are on the webcast. I'm assuming that ends at 1, but I don't think we're going to have time for questions before 1. So I would invite those who are with us to go ahead and stay after 1 and work into the lunch area, and we'll have a chat. So I want to tell you about the MASKS study. We've heard lots about animals. Question is, do they translate to children? And that's my granddaughter on the left. She's really cute. This is not an academic interest only for most of us. My granddaughter had a very serious illness when she was 3 weeks old and needed a general anesthetic. We all have similar stories. We care. One of the things that we need to do in the field is to try to define phenotype. If it happens, what's the phenotype? You can think of several different cognitive domains. You can think of things like psychomotor skills. You can think about behavior that might be affected. What's the trajectory of any change that you see? What might be moderators of any changes that you see? And are there any biomarkers that might be associated with such changes? The MASK study is an observational population-based propensity-matched design. 2 different branches. Both define anesthesia exposure as the number of exposures before the 3rd birthday. There's a retrospective component. We originally published work showing a doubling in the frequency of learning disabilities and ADHD in children exposed to prior to age 3 in a birth cohort of children born in 1976 to 82. We've already talked about reproducibility in animal work. It's very important to do that work when possible in humans as well, we believe. So we wanted to see if we could replicate those findings in modern anesthesia practice. So since we started using something other than halothane, pulse oximeters, those sorts of things. We also have what we call a prospective MASK study. This is what Dr. Sun has referred to as an ambidirectional design. So you're looking at people who have been exposed in the past before you start the study, but then you prospectively test them to see if you can find an association between exposure and some phenotype. We start with a retrospective study. I'm just going to spend not too much time on this. This has been out for a bit, but I do think it's important to understand what was found here to compare it with what we'll show in the prospective study. These are kids that were born from 96 to 2000 to mothers residing in our local county. We had the unique ability to have comprehensive medical record information, birth certificate information, and also school information for these kids. We propensity stratified samples of kids from each exposure category, so trying to find, for example, those kids that were not exposed that were otherwise as similar as possible to kids who were. We had a certain number of kids that we were able to identify in each of these categories, 126 that were multiply exposed to anesthesia, and we looked at 3 outcomes: learning disabilities, attention deficit hyperactivity disorder, and group-administered ability and achievement test scores. These are the results for learning disabilities, with frequency of learning disabilities on the left and the age diagnosis on the x-axis. You can see that for those kids who were singly exposed to anesthesia, in the red they had a very similar frequency of learning disabilities compared with the unexposed children in blue. I'm sorry, the battery's dying. Oh well. If you look at the kids that are in green, those are the multiply exposed kids, and you can see they had a markedly increased incidence of being diagnosed with a learning disability. If you look at the hazard ratios on the top, about doubled for the multiply exposed, no significant effect of single exposure. You can see that this is not an uncommon diagnosis in those kids. About 30% by the age of 18 were diagnosed with a learning disability. If you look at ADHD, you see similar results. You see, in this instance, there was a tendency, not significant, for single exposures to also be associated with an increase in the frequency of ADHD. The hazard ratios are, as you see there, over a doubling of risk for developing ADHD in the multiply exposed. As it turns out, the absolute values of the hazard ratios and the absolute incidences for both ADHD and LD were very similar. to what we saw in our prior birth cohort. So we were able to reproduce this result. If you look at group-administered achievement tests in reading, mathematics, language, and spelling for 0, 1, and 2 or more exposures, you can see that for the single exposure, so we're at the middle of the rows, that there was a small decrease in achievement test scores for those who were singly exposed for reading, but not for the other tests. There was a larger decrease in achievement test scores for all the other tests for those who were multiply exposed. By the way, these and all other analyses were adjusted for several factors thought to be important to neural development, such as sex, birth weight, and the like. If you look at a group-administered ability test, you can see a small effect of 2 or more exposures with a group-administered school test that is supposed to be, and it's controversial about whether it actually is or not, some measure of overall ability or intelligence. So if you summarize these results, you see that multiple but not single exposures to modern anesthetics prior to the age of 3 was still associated with an increase in the risk of learning disabilities, all 3 types of learning disabilities, and ADHD. Something also interesting, we know that these 2 things go together, and in unexposed kids, about 20% of the time it goes together, but it's particularly coexistent in kids who are multiply exposed. Almost 2/3 of those kids had both the diagnosis of ADHD and learning disabilities. Multiple exposures were also associated with modest decreases in the standardized tests of ability and achievement, and single exposures associated with modest decreases in subdomains of reading, but not in mathematics and spelling for achievement tests. Didn't find any evidence of factors such as sex or socioeconomic status or gestational age moderated these associations. Didn't matter whether you're a boy or girl, for example. On to the prospective MASKS study. So again, these are kids that were exposed in the past and that we prospectively recruited to test. So this is a birth cohort from 94 to 2007. Again, mothers that were resident in the local county that houses Mayo Clinic Rochester. We again had medical record information and birth certificate information that we could use to calculate propensity scores for the propensity to be exposed to anesthesia. So we were able to sample for targeted recruitment kids who were hopefully alike in as many ways as we could figure, who were not exposed to anesthesia, to kids who were. So we targeted a certain number of kids in each one of the exposure categories. The outcomes for this part of the study was an operant test battery, I'll mention that in just a moment, and a comprehensive neuropsychological assessment battery measuring domains as shown here. I'll give you some more details about that in just a moment. So the operant test battery, this is essentially a large mechanical video game that the FDA uses in toxicity studies for drugs. It turns out that kids can also do this large mechanical video game as well as primates. So we hauled one of these apparatuses up, installed it in our pediatric floor, and ran kids through this test. I'd love to tell you more, but we're not quite done with the analysis, and that'll be next year's talk. For the psychometrist assessments, several things. So the primary outcome was global cognitive function measured by the full-scale IQ of the WASI, Wechsler Abbreviated Scale of Intelligence. Other domains that were measured included visual motor integration, visual and verbal memory, visual spatial abilities, expressive language, attention, executive function, processing speed, and fine motor skills, using the tests that you see under each category. We specified a priori in an online publication or analysis plan which ones of these tests we were most interested in, trying to map the tests onto these pre-specified domains of primary interest. We also did things like calculating composite scores within domains when we had more than one test that we thought was going to measure the same domain. We also looked at parent reports of learning difficulties, executive function, and behavioral problems. And I'll emphasize that these are parent reports. These are not diagnostic tests. These are parent perceptions of how their child was functioning in various domains. So just to clarify the propensity sampling strategy, because this is a really important part of all studies in this area. You will never be able to find children that are exactly the same who have had and not had anesthesia. Kids who need anesthesia are inherently different. But you can do the best you can to match on other characteristics. This is what we did. So we calculated a propensity score for requiring anesthesia based on the factors that you see up there. That included use of the Hopkins ACG case mix system, a measure of overall medical utilization and comorbidity. We then created 50 strata that balanced on the y-axis the propensity for single anesthesia exposure and the propensity for multiple anesthesia exposure on the x-axis, both separately for males and females. So, for example, if you have a child who had a propensity score who was multiply exposed, they might fall in a particular strata. We then tried to recruit singly exposed children who also fall in the same strata, as well as unexposed kids who would fall in the same strata. Now, as you might expect, not everybody that you invite comes, and so you don't have perfect balance at the end of the day. In our retrospective study, we simply didn't look at the multiply exposed kids who didn't have a match. That's not ethical in children that you're inviting to come participate. So we did another propensity procedure using inverse probability treatment weighting after the recruitment was done to correct for residual imbalances in the covariates arising from children who were actually tested, not just invited. We were also able to include socioeconomic status at this point in this weighting procedure. So in terms of the overall recruitment, we started with almost 20,000 kids in the birth cohort. These were the exposure numbers for unexposed, singly exposed, and multiply exposed kids. We sampled from these the numbers of kids that you see here. We invite them. Some of them we could not invite, for example, because they had moved out of Olmsted County. So those are the numbers that were invited. Those are the numbers that were enrolled. And these are the numbers that actually completed testing. Overall recruitment rate of 32%, higher for multiply exposed than singly exposed and unexposed children. But we were fairly happy with that recruitment ratio. We also did some work comparing the characteristics of those who responded and didn't respond and found very few differences among them. In terms of the anesthesia and procedural characteristics, singly exposed median duration of anesthesia was 45 minutes. Multiply exposed was a little over 3 hours. The most common procedure that these kids underwent were ENT procedures. About 4% of them received cardiovascular and neurologic surgeries. And about 80% of them received sevoflurane nitrous, which on the one hand, if you're trying to compare different anesthetics, is not good. But if, on the other hand, if you're trying to have a consistent experience, many of these kids did have a relatively consistent anesthesia experience. These are the results looking at the standardized differences in various characteristics. Before and after, we applied this inverse probability of treatment weighting procedure. Again, this was to correct for residual imbalances after we had actually recruited the kids. You can see that before we did this treatment weighting, we did have some differences in the red circles there, but that after we were able to apply this procedure, that really there were few differences between the multiply exposed and the unexposed on the left column and the singly exposed versus unexposed in the right column. So again, we were fairly happy that we had matched these kids as much as possible among the exposure categories. In terms of results, let me orient you. This is the primary outcome, the WASI full-scale IQ. You'll see an x-axis here, which is an estimate of the standardized effect, so the difference between either single and multiple exposures compared with unexposed kids. You can see that it ranges in this slide from minus 0.5 to 0.5 standard deviations. Single exposures will always be in blue, and you'll have the mean effect with 95% confidence intervals indicated by the line. And you can see, for example, there was very little standardized difference of single exposures. There was also very little difference with multiple exposures. So no significant effect on the primary outcome of WASI full-scale IQ associated with exposure status. If you move through the rest of the domains that were tested, this is the attention domain, the two tests that we pre-specify we would be most interested here. You can see, again, some small variations, nothing close to significance. These are tests of memory. These were mainly done with the wide range assessment of memory and learning. You can see that overall, not much evidence for differences. You can see that for multiple exposures, for design memory, some small effect that approached significance. The one thing I tell you that that particular test, among all the rest, required motor skills. That will become significant in a moment. I want to show you one other thing, which is the estimate for all of these values for the unexposed kids. So for example, if you look up at the full-scale IQ, you can see they had an average IQ when they were unexposed after all the analytic procedures of 106. The green values indicate where those values for the unexposed kids are outside of the population norms, which for IQ, being a standardized test, is 100. So these kids were a little above average. They're Minnesota kids. They're all slightly above average, right? And you can see that that was the case for many of these other tests, except for the design memory, which is kind of interesting. But this just gives you some context for how to interpret these differences. So that these are, for example, starting with kids who are already a little above average in many of these domains. So really no effect at all. If you move on down, these are tests of executive function. Again, you can see no significant effect for either single or multiple exposures. This is a test of expressive language, no significant effect. Visual motor integration, close, but no significant effect. Visual spatial comparisons, no significant effect. Rapid naming through the C-top, significant effect of multiple exposures. This is a task where kids are able to rapidly name a string of letters or numbers, and it's how fast they can name them. So multiple exposed kids were a little slower than their controls. If you look at a composite of fine motor, which was grooved pegboard and the Berry test, you can see that, again, there's a significant decrease in kids who were multiply exposed to anesthesia. They're a little more clumsy, if you will. It's not a huge effect, right? Looking at about 0.38 or so for a standardized effect estimate of differences, but significant. These, again, are the norms for the unexposed children. Again, seeing they're relatively normal, except, interestingly maybe, for the fine motor composite. Even the unexposed kids were a little more clumsy. How about the parent reports? This is the brief, which is a report of executive function. You can see that the effect estimate was significantly greater for both singly and multiple exposed children. Greater means more problems, okay, for all of the parent reports. If you look at the childhood behavioral checklist, you can see that for the singly exposed, no significant difference. For the multiply exposed, reported more problems in all of these areas. Internalizing problems, externalizing problems, total, and ADHD problems. If you look at the Colorado Learning Difficulties Questionnaire, no significant effect for math, but some effect for both single and multiple exposures in reading. So the parents think they're different. The parents think they have some problems with executive function, some problems with behavior, and some selected problems with learning. I want to emphasize this is not that they're having terrible difficulties. If you look at, for the unexposed kids, these are t-scores, so the mean is 50. So the unexposed kids had less than normal problem reports. So the more exposed kids have more problems, but it's not as though they have tremendous problems, if that makes sense. So overall, if you look at the domains that we measured, no effect on the primary outcome of global cognitive function, selective, small impairment in processing speed and fine motor skills among the multiply exposed children. No effects in the singly exposed children. If you look at the parent reports, we see an increase in reported learning difficulties in singly and multiply exposed kids in reading only. We see an increase in problems with executive function for single and multiple exposures, and increase in behavioral problems for the multiply exposed. So, to summarize the results, exposure was not associated with the primary outcome of IQ. Multiple exposures associated with modest decreases in processing speed and fine motor skills. No other changes in any other testing domain. Increased parent reports of more problems with reading, behavior, and executive function. The caveat, these are secondary outcomes and these are multiple comparisons. There's ways analytically to get around that we're working on, and I can tell you that when you do that, you're still going to find that kids who have multiple exposures have a small decrease in their fine motor skills and processing speed. Single exposures, no change in any neuropsych testing domains, but some parent reports of more problems with reading and executive function. We also did moderator analyses, no moderator of any of these effects. It didn't matter whether they were rich or poor, male or female, high or low birth weight, age of testing. So if you look at the two parts of our study, the retrospective and the prospective, these are the results for the retrospective, where we see that there is, for multiple exposures, effects on both achievement tests and learning disabilities. On the prospective side, we also find for single exposures that we have some evidence of increased reports of reading difficulties. For the reading difficulties that are self-reported, we see those only in among multiple exposed kids in reading and not math. In terms of behavior, we have, for multiple exposures, a significant increase in the reports of ADHD. We see multiple problems that are in the child behavioral checklist and executive function, so those are consistent with the retrospective results, as well as a few hints in singly exposed kids on the CBCL. PANDA, Dr. Sun's study. Similar in some ways to what we looked at for single exposures. They looked at herniorrhaphy specifically in sibling matched pairs. If you compare the things that we both measured, neither found any effect on full-scale IQ, no differences in neuropsych assessments. They did find, if they looked at people who were greater than a threshold for the CBCL problems, they found a small increase in the proportion of kids who had abnormal internalizing problems. We found a small increase in the proportion of kids who had abnormal externalizing problems. We found differences in the brief, they did not. We found small increases in reading difficulties, and they did not measure that. And by the way, they have a much cooler logo than we do, as you can see. So does all this make sense? I mean, because we found this relatively dramatic increase in learning disabilities and ADHD in the retrospective work, but not much effect on these neuropsych tests. Well, certainly learning disabilities can be associated with disturbances in visual and verbal memory, executive function, and attention, and we just didn't see any evidence for that in our prospective study. Similarly, for ADHD, typically you can see changes in measures of attention and executive function that you measure in neuropsych tests. However, you also tend to see problems with processing speed and fine motor skills, and certainly for the multiply exposed kids, we did see that. Same thing for learning disability. They also tend to have problems in processing speed and in fine motor skills. And again, we have a high proportion of kids in our retrospective work who exhibit both. If you look at the correlation within the parent reports and the neuropsych reports, so this is all on the prospective side, there's a pretty good correlation between parent reports of ADHD behaviors and reading difficulties. There's pretty good correlation, not as good, but not bad, correlations between things like reports of ADHD problem and problems with fine motor skills. Across all of these things, you can see the correlations that you see. So, is it that these relatively subtle decreases in processing speed and fine motor skills are sufficient in order to cause some of these reported behavioral and learning difficulties? I'll leave that to you to decide. Take homes. So we consistently see exposure-related changes in just a few of the neuropsychological domains that we tested. These are modest and specific: fine motor and processing speed. And they're only associated with multiple exposures. So overall, this continues to be very reassuring for kids who have single exposures to anesthesia. Certainly on those tests, we see very little evidence of association. However, the parents, the teachers in the form of the teachers that administer tests, and clinicians think that children exposed to anesthesia do have more behavioral and learning problems. There's some evidence of this with single exposure, consistent evidence with multiple exposures. There's some potential, and there's lots of limitations with this, some potential for bias in terms of reporting and the like that we can talk about in the discussion session if we have time. But this is the data that we see. The question that we're left is, are these problems consistent with the neuropsych results? What would you expect to see? Is anesthesia, is the phenotype different than kind of wild ADHD or learning disabilities? And you have some hints of that because of the high co-occurrence of the two. We require a little more study and analysis. We still haven't directly looked at the translation between children and animals. We're analyzing those OTB results, but I just note that learning and memory are often assessed in many of the rodent models. And for most of the tests of learning and memory that we examine in our study, we don't see any association. Finally, the usual caveat that these do not at all apply causation. You have to take these results in coincidence with all the other results. This is not to say that you can't make causal inferences from an accumulation of observational and experimental data. The neurotoxicology literature, environmental exposure literature does this all the time. This is one piece that you have to put in the rest of the puzzle in order to try to come up with your approximation of what the truth is. But we hope that this will be a useful piece for the community. I do want to acknowledge the whole team. This was a 6-year, multiple investigator effort that was supported by NIH. I want to especially recognize Bob Culligan, who was one of our neuropsych psychologists who unfortunately died during the conduct of the study, and he is sorely missed. Thank you, Bob. And for those of you that do clinical research, you know that the lead coordinator is the one who makes it work. She recruited 1,000 kids on time and on budget over a 4-year period. Bless you, Shani. Thank you very much. So I think for those who do want to stick around, we will be up here, and if you want to ask some questions, we'd be happy to answer.
Oh, no.
Okay. So Dr. Orr has to go. Are you available?
I'm available.
Okay. So
right, we'll do our best.
Okay.
Please, yes, go ahead.
Can I? Yeah.
Sure.
So, Mike Crowder, UW. Actually, I was going to make a comment. The Bev doesn't have to be here for this comment, but it's about what Bev said. And then I also had, if I have time, a comment for you, David. But you know, the thing about reproducibility in science, one problem is that sort of all the incentives are stacked against it. I'm chair of the Appointments and Promotions Committee at the School of Medicine at UW, and we still have people saying, counting papers and not thinking about the quality of those papers. We all do it. We introduce people and say they've published 300 papers as if that's a good thing. And I would just say to people that we need to stop doing that. And there's lots of other incentives, but very little disincentive to publishing bad science. So that's my comment for Bev, and I really appreciate that. And I think it's really important for us to all try to change our ways, because we're all guilty of it to varying degrees. My question for David is, so assuming that there's not some vulnerable window that we're missing, maybe that's only like a week in the life of a baby or a child that's really vulnerable, and the rest of it's just gone, and that could be true. I would say that this means that the very worst case scenario is what you're showing could all be due to anesthesia. The other possibility is that none of it's due to anesthesia, and it's all due to the complexity of the fact that they're having multiple surgeries. And so I would take this as good news and reassuring for parents and for all of us that we're not probably hurting children that much. Yeah.
I agree. I think the fact that the result that we have is so specific makes you really wonder about the potential for confounding by indication. It's just hard to imagine what common indication would be across all the different indications for surgery, because this was a population-based study, this was all comers, why every child who needs anesthesia happens to be a little slow and a little clumsy. I don't want to use clumsy, flippantly, but that's my way of saying fine motor skills. It could be, but makes you wonder. But yes, overall, I think that overall these kids are not devastated. They're not running around with bad problems. Everything else being normal is enormously reassuring. That's not to say that, and we haven't detected any moderators yet, so we don't know if there's some kids that might be more vulnerable or this might be more pronounced. If it's happening, we don't know. We just know that on a population level, there does appear to be enough of a common effect that you can pick up these significant differences.
I guess I had a question, maybe following along that. The mask data you showed for the prospective mask was for children who are exposed between 8 and 12 years of age. Are there any plans to do something like that for kids exposed at a younger age?
Well, these were actually exposed from 0 to 3.
Oh, okay.
They were tested in 2 groups. I didn't have time to go through that in great detail. So they tested either from 8 to 12 or from 15 to 20.
I see. Thanks for that clarification.
Because we wanted to see if we did see an effect, whether there was any evidence of progression of effect or resolution of effect, and we did not find that. In other words, the things that we saw were similar regardless of those 2 broad ages of testing.
So, hi, Stu Foreman from MGH. Dr. Warner, you mentioned that 42% of the children who had anesthesia were having ENT procedures. I assume that's myringotomies. Is that, or am I?
Certainly many myringotomies, but also
for delayed
language,
which is usually done for delayed language acquisition. Mm-hmm. I don't know, how that impacts on other developmental milestones that you may have included in your study. So do you compare the incidence of delayed language in the control group versus the exposed group?
Well, we don't have a measure of delayed language per se that we're measuring. We just are measuring at that one point. We haven't done it for the prospective data yet, but for the retrospective, we did a sensitivity analysis and actually threw out all the myringotomy kids, and there's no difference in the risk.
I would like to review briefly what we found and what Mark Baxter's lab found in the primates. I think one thing that is similar is that we found we had the experimental paradigm was also single exposure versus multiple exposure versus no exposure, and Dr. Baxter had multiple exposure and no exposure. And so we found in our animals that the motor reflex development was delayed in single exposure, but way more in multiple exposure. Then after 1 year, both our labs found that the animals had an altered response to stressful stimuli. And then we found also in field observations by blinded observers over a 4-week period of all the animals that the animals after one and also after multiple exposures were less interacting with their peers as compared to those that were not exposed, and maintained some degree of an altered response to a stressful stimulus. And then Dr. Baxter recently found also at 2 years of age an altered response to a novel object. And so I think that is in its own way and limitation similar to elements that you found in the prospect, in the bidirectional study, and if you will, shows a phenotype that is altered after anesthesia exposure at a very young age when you follow the primates, non-human primates, at later ages where they are in the range of school age kids, if you will, from their development. Is that about fair? Yeah. So I find that in that sense very reassuring, because we are on a way of developing an understanding of kind of a schematic of the phenotype that is similar in non-human primates, and then more so in humans, which may guide us to understand what endpoints to follow in further studies, both in animals as well as in humans. For example, the interesting coherence between all the clinical tests that show that there's no effect on the absolute number of IQ, for example. That's important, then we can leave that alone. And it's different things that we need to focus on.
Right. Now, I hope that this will provide some guidance for the preclinical work and for some other of the clinical trials and other investigations that are being planned. It would have been nice if we had found some very obvious, simple thing that was reduced, I guess, from an experimental, not from a child standpoint. But it looks like we will have to look at things like behavior, more subtle things like these relatively sophisticated tests of fine motor skills, as we start to plan what would the future, if we're going to do more randomized trials or more observational studies, we're going to have to be subtle in what we look for.
There's a question over there. You.
Thank you to all the speakers, Jerry Chow from Einstein Montefiore. In taking the results that you presented, Dr. Warner, and in thinking about it and contextualizing it, are we capable of informing policy at this time vis-a-vis the FDA regulations and label changes? And where do you see, you started talking about this a little bit, where do you see us going from here in terms of future clinical studies? Are there more roles for observational work? You know, there's the gas trial and T-Rex. You know, what are the future directions, given that we're looking at very subtle effects, it seems?
I think the most important future direction is biomarkers. I think, and that's probably going to be imaging. If there really is something that's this specific in terms of fine motor or processing speed, you really may see it if you look at kids' brains. And if you look at the experience of environmental toxicologists who are trying to make links between exposures and some sort of phenotype. It can actually be more consistent to look at the biomarkers than some of these phenotypes, which are quite variable and related to a lot of other factors that also affect development. So be it imaging or other tests, I think it's going to be important to look for that kind of association. In terms of the implications for regulation in the FDA, that's not for us to say, and I think I don't want to, I mean, I'm practicing pediatric anesthesiologist, so I have to deal with this, but I don't want to say that any single study should change one thing or another. I do think that we just need to get more data like this, go back to the FDA and have more discussions with them saying, all right, since the last time that we presented this, we've got now 3 major human studies that have been published. Let's talk some more about what the state of the evidence is, and let's make sure that if there are things that the FDA say, it's informed not only by the animal work, but also by the more recent human data as well.